Morning, everyone. Good morning. Simon's in. Welcome, Simon. Yeah, bank holiday, bank knee holiday. Absolutely. I'm loving your. You should write T-shirt slogans. It'd make a fortune. Good to see you guys. Hopefully we've got a few here today to make me coming in on a bank holiday worth it. So we're going to carry on from what we did last week. I had a bit of a plan to do loads of stuff on the muscles of the knee, but then the questions kind of took it on a different direction, which is exactly what this is for, to be honest. So. Yeah, it was a really good session last week. Morning, Tristan. Good morning. A welcome break from the dust in your house. Hopefully, be good to see. I haven't had a look at any pictures recently. I've just kind of had a bit of a break from Facebook, so it'd be interesting to see how you're getting on. We were, you know, what it's like when you spend a bit more time in your house. You're thinking, oh, I must get that done, and yeah, thinking about getting a bit of building work done. And then I see your pictures, and I'm like, oh. I got to go through that again. Cool. Right then, let's get going. So, yeah, last week we looked at this. So, this is where we finished. So, we were talking about valgus and varus knee positions. Just going to get my arrows here. So, and then I think it was Becky that mentioned about the differences between male and female. So, obviously, with a female, they've got wider pelvis. So, the position of the hip joint is in a wider position, so the knees are more likely to come inward, so more likely to have this kind of valgus position. But as I was saying before, we used to think that this was a predisposition to injury. But it's more likely to be a sudden increase in loading rather than the actual anatomy. So there's been a lot of work done, especially with female footballers, where they're conditioning that knee valgus movement so that they're less likely then to get ACL, MCL, and medial meniscus injuries. So they're commonly called the unhappy triad. So usually in this position. So this is the position it happens in, is a valgus position, and then with body weight going through and a twist. So typical kind of change of direction type movement, and if you have an external force as well hitting you from the outside. So if you imagine someone landing on a sort of fibular head area or tackling you in a game, then that's going to open up the inside of the knee a little bit more. So I mean, there's nothing you can do about traumatic injuries. They kind of are what they are. But the non-traumatic ones, we try to look at the data to try to prevent those. But there's no such thing as injury prevention. You can't prevent injury. But what you can do is try to reduce the risk or reduce the likelihood. So yeah, so that's where we are with that, really. Morning, Catherine. Good morning. Good to see you live. And good morning, Julie. Oh, we've got a few regulars in the group, and I think I might have missed you. So morning, Neil. How you doing, mate? Good to see you. Cool. So yeah, if you've got any questions about that kind of stuff, then pop it in the group. I'm happy to point you in the direction of papers that kind of talk about all the stuff that I've mentioned today. And that, in fact, that brings me on to something that I've forgotten to start with. So in our Facebook group and on the Sports Therapy Association group a couple of weeks ago, mentioned about doing some mentoring. And so what I'm planning to do is do another kind of little Facebook group like this where we look at pathology and I try and link it up as best I can with the anatomy. So it'll be a follow on from this session. So if you want to do some kind of group mentoring where you can all ask questions and kind of no question is a stupid question sort of thing, then we're going to start another little Facebook group that's going to run after the Learn Anatomy Online. So it'll be 10 till 11 and then 11 till 12. So that's something that we're going to start in the new year. And it's going to be probably me that will lead it initially, and then we'll get some of the other tutors from movement therapy education involved in that as well. And then if you don't want to do the group thing, but you want a bit more of a bespoke sort of package, then we're doing the opportunity to either do Zoom calls once a month. So we have a look at your practice and what you're doing. You can run through some case studies or whatever you want to do. or you can. So that's one bit of it, and then the other bit is where you can also come to my clinic or some of the other clinics of some of the other mentors, and you can observe them while they're at work. So you can actually see what we do in practice, and it's quite often it's like, is that it? And basically, we don't do anything fancy. We just do the basics, and hopefully, we do it really well. So yeah, hopefully, it'll give you a bit of confidence to see things in the workplace. So we're going to be launching that in January, first week of Jan. That'll be live. So you've got three options, and they're three options based on. Sort of how much you can afford, really, as well. So we didn't want to exclude anybody. So you've got the group stuff that will be very similar price to this. Then you've got the one-to-one mentoring, which is on Zoom, and then obviously the clinic visits. So depending on what your budget is and what you want to do, then there's different options depending on what you want to do. So so that's where we're heading. So just wanted to give you a bit of a heads up about that. And yeah, it kind of leads into all this stuff because we do get asked quite a few questions about patients, and it's really difficult. Basically, if someone is answering a question online about a patient, ignore them. If you put a question in about a patient and then someone gives their opinion, you have to ignore that opinion, because unless behind the scenes you've given some additional information, there is no possible way that you can work out what is going on with someone after maybe a paragraph of a sentence, of a description. Sorry, so it's absolutely impossible. So yeah, so that's why we thought about putting these groups together so that we can discuss things properly, like you would in a multidisciplinary team. So that's the idea with that. So yeah, just kind of got me thinking about that when we talked about this. Cool. Let's get back to the anatomy. So we've looked at the front of the knee, and we've looked at something called the patella, and we saw the shape of the patella, and we also saw a video where when the patella wasn't in place, the amount of effort it would have required for you to extend the knee with just the muscles alone. So that patella creates a fulcrum, which then improves the efficiency of your quads. Okay, so that's what the patella does. Very good at doing that job. There's also something that I think it was Becky Carroll that came up with this a little while ago, or mentioned it, and I'd completely forgotten about it. Something called the fibella. Now, let me show you a picture of this. So the fibella, this might be interesting if you've been doing some treatment for the back of someone's knee, around the hamstring and tendon area, and you're thinking, blimey, that feels a bit tight. And it might be because it's a bit of bone. Okay, so I don't know whether you can see on the X-ray there, but there is a floating bit of bone here. So you've got your patella at the front, then you've got your tibia. You can just about make out the fibular head just there, and then that little bit of floaty bone there is a sesamoid bone. So it's a sesamoid bone, sometimes in the tendon or origin of the lateral head of the gastroc muscle. And because your gastrocs attach above the knee, so we'll have a look at that in a second, you might think it's kind of hamstring area. But and sometimes you can develop these around the hamstrings as well. Yeah, you've got a bit of bone sometimes in the back of your knee, and it's more prevalent than you think. So depending on the studies that you read, it's between 3 and 87%, but the median rate of the prevalence is around about 30%. So 3 in 10 of your patients roughly are going to have fibellas in the top of their lateral gastroc. So it's fairly common. There's no difference between genders or dominant knees, so it doesn't matter if it's one side compared to the other. But with the thinking is it's developed because we're taller and heavier than we were 100 years ago. So we're starting to develop bones to improve the efficiency of the muscles in the lower limb because we weigh more. I don't know, it's a sad indictment of our progression as a species. Remember that the patella does to the forces generated by the quads. The fibula is purported to do the same. Okay, so and that's from this study here. So you can can't copy and paste it, but you can type that study into Google and you can have a read of that yourself. So it's quite a recent recent review, that one. Cool. So yeah, just you know me, I love all the kind of weird anatomy stuff. So that's one that you might not have heard of before. So then we've got this term genicular, which is a Latin term or comes from a derivative from Latin, and basically knee is geniculum in Latin. So what you'll find is that we've got all these phrases like geno valgum, geno varus, genicular, geniculate. I've got some of them down there, and they're all to do with the structures around the knee. Okay, so when we get to the blood vessels, you'll see that there are genicular arteries, and you've already seen genu valgum and geno varum. So Catherine's just asked a question. If a fibula was found, would it be in the back of both knees or just one? It can be either. It doesn't have to be just one. Yeah, we think the body develops it over time. But like I said in the studies, it didn't matter whether it was the dominant or non-dominant leg. But weirdly for me, I think if you're right-footed, then quite often your left leg will take a lot of the load of the activities that you do. So you might not have ever noticed it, but if you're right-footed, you tend to lead with your left leg going up the stairs. If you kick a ball, then your left leg is planted, so it needs to be nice and solid for you to be able to kick with your right leg. And if you jump and you're right-handed, you jump off your left leg. So it's not surprising that what you would consider the non-dominant side to have more load going through it, because that's the stable leg whilst you're doing your activities with your right side, and obviously vice versa if you're left-handed. So yeah, it can be one or the other, and it doesn't matter which one. There doesn't seem to be from the review that was done a clear pattern whether it's one or the other. Okay, good question. Cool. So we looked at the ankle in quite some depth on the last sessions that we did, and then obviously we've moved up to the knee. There are some muscles that cross over the knee joint that are from the ankle region, and we've already talked about one. We've talked about the gastrocnemius. So we're going to finish off those. And what we did last time was had a look at the structures that attached over the ankle. We're now going to have a look at where they attach above the knee. Okay, so that's where we're going next. So we've got gastrocnemius, and if you remember to do the compartments of the lower leg, that this was the superficial posterior compartment, so the one that's closest to the skin, and it's at the back of the leg. Okay, and remember the leg is below the knee and the thigh is above the knee, so anatomically that's what they're called. So the origin and the insertion, we don't really use those terms. I might have mentioned this a few times. Don't really use those terms in anatomy. We just call them attachments. So the proximal or distal attachment usually. So the origin or the attachment that's closer to the midline of the body is the posterior, lateral and medial condyles of the femur. So we've had a look at those when we've been looking at the bones and structures of the knee. And then the insertion, which is what we've already seen. So the distal attachment is the calcaneus via the Achilles tendon. So joining in with the soleus muscle, they attach down onto the back of the heel. And then the action was plantar flexion of the foot. But because it crosses the knee, it is a very weak flexor, but it will flex the knee as well. Okay, so because of where the attachment is, when you contract your gastroc, you will get some knee bend too. Okay, so that definitely happens as well. And then this one sits on the back of the knee. We talked about this with the screw home mechanism of the knee. And we said that when the leg is extended, we get this lateral rotation of the tibia on the femur to lock the knee in position, and then all of the ligaments are nice and tight and the knee's nice and solid. Well, if we have a look at what popliteus does, this is the unlocker of the knee. Okay, so medial rotation of the tibia, flex knee, lateral rotation to the femur when it's in full extension. So we get this locking and unlocking mechanism from the popliteus muscle. So if you have a look where it attaches, right on the top of the lateral femoral condyle just there, and then it wraps all the way around the back of the knee, and we'll have a look at that in a second. And then you've got another really long muscle, and we discussed this briefly when we were looking at Achilles tendinopathies. So if you have a look at the pathway of this muscle, it's a really small muscle belly and then a really long tendon, and this is often used in grafts. So there you go, used in grafts for the hand, because of the long tendon. So if you damage some of the tendons in your forearm, they may take a graft from plantaris and then use it for your hand. And it's because it's not really used that much, okay? Because it is a very weak plantar flexor of the ankle, and also a very weak knee flexor. So because it crosses the knee, again, it will have an action on the knee, but because of the size of it, it's minimal. Okay, but the interesting thing with this, as we get around here, sometimes it joins into the Achilles and on the medial side of the Achilles. So you may have a plantaris issue that is irritating the medial aspect of your Achilles. So it's not a gastroc problem. Sometimes it can be a plantaris issue. Okay, so just something to have in your mind when you're thinking about what might be going on with someone. So lateral supracondylar line of the femur. So supracondylar is above the condyles, and then down onto the calcaneus. Okay, so that's where that one goes. So let's have a look at those. Just get the right videos up here. Get rid of that. Here we go. So here's gastroc. Hopefully, just play that one. No, it's not. Get rid of that one. Hopefully this is gastroc. Here we go. Okay, so just pause that there. So yeah, so this is going back to some of the stuff we did in the ankle. So you've got your Achilles tendon there, and then the two bellies of your gastrocnemius muscles there. So these big two bellies that then join into one Achilles tendon. And the bit we're interested in now, because we're up at the knee, is this bit around the knee. So they kind of go up and then fan out at the top, and it creates a space here, like a diamond shape at the back of the knee. So they got the hamstrings coming down, and then the gastrocs going up, and it creates a diamond in the middle, and that's called the popliteal space. Okay, so within that diamond, that's where you've got your neurovascular bundle. So the nerves and the arteries and the veins all coming through that back of the knee. And we had a look at the capsule at the back of the knee last time we were here last week. So let's have a look at this. So there's your diamond. Oh, just move me out of the way. And that's where your gastroc attaches. I'm getting in the way of everything here. Here we go. So I don't know why that symbol is there. I need to remove that. So it's not approximately the fibula head. That is your fibula head. And then these are the femoral condyles. Okay, so that one will be the lateral one because your fibula head is on that side, and that's the medial one. So the gastrocs will come up, and then they'll fan out, and then they'll hook onto those condyles. So this is why the gastroc has an action on the knee, okay, because of its attachment just there. So let's have a look at those. Oh, I think that was it. So there you go. And then let's have a look at popliteus. Just get that one up there. Get rid of that one. Here we go. So this is popliteus. Just there. So it's the knee unlocker. There's your soleus muscle. So broad attachment on the back of the tibia, and then a small attachment on that lateral femoral condyle just there. Okay, and oh yeah, let me just pause that there. So when we were looking at the joint capsule last week, the popliteus actually pierces the joint capsule. So it goes through the joint capsule, and there's a covering around it. So it's not like a hole is there. Kind of as it goes through, there's all this kind of webbing around it, and then it will come through onto that condyle of the femur. So through the joint capsule just there, and then up and onto the femoral condyle, which is what we saw before. So let's just play that again. Here we go. So there's your popliteus. So this muscle just here, so you can see the broad. It's got quite a broad belly to it and very little tendon. So it's quite a powerful muscle, this one, for the size of it. And then you've got your soleus underneath, so it kind of it follows the line of the soleus and then pierces the joint capsule just there. If I just play this. There we go. So there's your posterior tibia and then just a tiny, tiny little insertion just there, okay, on the lateral femoral condyle. Cool. So that's your popliteus muscle. So that's the one that we were talking about is your knee unlocker. And then the last one for this area, which we've just looked at, is plantaris. So let's have a look at that one. And that's this one just here. So if I just pause that there. So there's your plantaris muscle belly, just there. There's your popliteus just behind it. And then your soleus deep to that as well. And you can see here that really, really long tendon. So it's very, very thin, long tendon. And then that will then join up with your Achilles, or might be just slightly separate to the Achilles as it goes down the leg. So we can see that there. There we go. So it comes from all the way up there, and then really, really long tendon all the way down, and then into the Achilles. So you can see why that one would be good for using as a graft, because it doesn't really do much. And you can survive without it, and so obviously it would be very useful to use as a graft in the hand if you needed it. I think the sometimes, if I just go back to that screen, sometimes you'll find that if someone has injured their Achilles and it's been ruptured and they try to plantarflex the foot, they can still do it, but it's very weak, and that sometimes is plantaris. So that's why sometimes the active range of motion test for that movement doesn't tell you whether there's an injury there or not, because you might think, oh, it just looks a bit weak, and that's why you do the belly, the muscle squeeze test, the Thompson test. So if you squeeze the belly of the gastroc and it's ruptured, the foot won't move. But if you try to plantarflex the foot, it will, because of plantaris. So that's why that Thompson test is a pretty good one to check. Cool. Right. Let's have a look at the next one. So that was kind of finishing off the leg, and then the influence that the leg and some of the muscles that attach and tendons that attach onto the ankle have on the knee as well. We're now going to have a look mainly at the thigh. So before we do that, we need to have a look at the compartments of the thigh. So when we looked at the leg, and we were looking at all of the different sections of the muscles that control the ankle, there are also compartments in the thigh. And we mentioned this a little bit last week, but we'll go into a bit more detail now. So there are 3 compartments in your thigh. Just grab my arrow back, and hopefully you can see each of these colours and how they're separated. So there's your femur, just in the middle there. So obviously we've got there's just the thigh bone on this one. There's no because obviously in the lower leg you've got your tibia and the fibula, so it kind of confuses things sometimes. And then in between, so each of the muscle compartments are coloured on this picture, and then they're separated by these lines here. So there's the lateral intermuscular septum. So that one just there. And that will separate this front compartment, so the anterior compartment, from the back. Okay. Then we've got this posterior intermuscular septum just here. So that separates your posterior compartment, the muscles at the back there, from the medial compartment, the ones on the inside of your thigh. And then we've got this medial intermuscular septum just here that separates the front from the inside, so from the medial aspect. So we've got, and these septum, if you remember the fascia lata from last week, they come out from the bone, so they attach onto the bone, and they spread out and then attach onto the fascia lata. Yeah. So that's what keeps everything kind of in in place. And we saw an image of that last week. Well, I think it was well, it must have been the lateral intermuscular septum attaches onto the fascia lata on the outside of the thigh. So, and it's quite a tough fibrous connection, and so that is very similar to the lower leg. So if you have an injury to the, let's say, the posterior compartment, so say you've bruised, you've torn one of your muscles, so you get a lot of bruising, it will usually accumulate in this compartment. Sometimes it will seep down into the leg. I've seen hamstrings that have been torn, and the hamstring looks fine initially, but when you do an assessment of them and you have a look at the whole leg, they've got bleeding in their heel, and it's because the blood has trickled down through the compartments into the heel. So if you spot, sometimes you have to look further away from where you think the problem is. So it can be contained within the compartment. If you get a bleed in a certain area, so say here we've got the deep femoral vessels just here. So you've got your femoral artery, femoral vein. So if there's a femur fracture and then it impacts on that artery, so it tears the artery will bleed into the compartment. Okay, so obviously we have to be aware of that with traumatic injuries. So things like rugby and football, leg breaks in football, especially. Yeah, very, very similar to compartment syndrome in the leg. You can get compartment syndromes in the thigh as well. Okay. So what we're going to do is we're going to have a look at each of these compartments sort of one by one, so we can group everything together. And this picture is really good because what you'll notice is that each of the compartments has got its own nerve supply. So when we're looking at what nerve does what to what region and what actions they produce, it's all down to the compartment. So very similar to the leg, where you've got certain nerves going in certain compartments, and then whatever muscles are in there, they're the ones that they innervate. It's exactly the same here as well. So on the front of the thigh, all of these muscles, if you have a look, there's your femoral nerve. So these muscles all here pretty much are innervated by your femoral nerve. Okay, and then on the inside of your thigh, so the medial compartment here, I don't think it's on here actually. I don't think there's a picture on there, but there's a specific nerve that innervates all of that medial compartment called the obturator nerve. And then the one at the back is the one that you will all probably know is your sciatic nerve. Okay, so each compartment has a nerve. So if you lose the action of some muscles and it tests weak, then you'll know what nerve it is because of the compartment that it supplies. Okay, so it makes it a bit easier to work out. Cool, hope that makes sense. So let's have a look at the anterior compartment. So the first one is your rectus femoris muscle. So enough of me going on. Let's have a look at it first. Just get the right video. Hopefully this is the right one. Yep, it's looking good. Okay, just going to pause that there, move me out the way. Cool. So we've got, this is your pelvis. So this is a view of a right leg, looking at it from the front. That big lump there is called your greater trochanter. We haven't covered anything up that far yet because we've been looking at the knee, but you may have heard of that already. And then we've got areas on your pelvis which we'll be introduced to now because of the long attachments of these muscles. And yeah, that was the one thing I asked you to have a look at was something called Lombard's paradox. So the rectus femoris muscle attaches above the hip and below the knee. Okay, so when you go down into a squat position, so when you're stood up tall, and then you start to descend onto a chair or whatever you're going to sit down on, the top portion of your rectus femoris, which is up here, will get shorter because you're closing the hip. Yeah, you're flexing the hip. And then the bottom part where your knee is, you're also flexing the knee, but that will stretch the last bit of your rectus femoris. So, and this is Lombard's paradox. So as you descend into a squat, the top part of the rectus femoris gets shorter, the bottom part gets longer. So actually the muscle length doesn't change. Okay. So what, and this is what the Lombard came up with. So it's more like an isometric contraction because the muscle doesn't change length. Okay, rather than an eccentric, concentric, if you've heard of those kind of things before. And the same is true for the hamstrings because they cross the hip, they go up into the ischial tuberosity on your pelvis, and then they cross the knee as well. So exactly the same happens there. But as you sit, the top part of the hamstrings will get longer and the bottom part gets shorter, so they don't actually change length. So again, it's more isometric kind of contraction than it is concentric, eccentric. So that's Lombard's paradox. So let's have a look at these. So this is your rectus femoris muscle. To just give you a bit of an orientation again. So this is your ASIS, so anterior superior iliac spine. And then just where the rec fem attaches, rectus femoris, is your AIIS, so anterior inferior iliac spine. So that's around this area here. There's also another little attachment, which a lot of people don't really know about, of rec fem, which is here. So it's got two heads, rectus femoris, at the hip. You've got a small head or small attachment that is on the supraacetabular groove. Okay, so we know supra means superior, so it means above. You may not have heard of acetabula before, but you will do when we get to the hip. The acetabulum is the socket of the hip. So there is a little groove just above the acetabulum, and one slip of the rectus femoris actually attaches into there, and then the other slip attaches onto the AIIS. Okay, so anterior inferior iliac spine. So that's that bit there and that bit just there. Okay, so you can see them a little bit easier, a little bit cleaner there. And then that muscle comes all the way down and then joins into your tendons at the bottom. I'm just going to pause that there. So you might have heard of the patella tendon, and we were talking about that last week, whether it's a ligament or a tendon, because it attaches bone to bone rather than muscle to bone. But this one definitely is a tendon. This is your quadriceps tendon. So your patella is sitting in there somewhere, and there's your rectus femoris. And just before the rectus femoris attaches to the patella, there is a tendon junction just before it. Okay, this is often a site of patellar tendinopathy as well. So we tend to think of it down here, but actually the more and more people I treat with this, we're finding that they have some real irritability on that quadriceps tendon, as well as the apex of the patella just down there. This muscle we haven't had a look at yet, but this is vastus medialis. We're going to have a look at that in a sec. The one we're interested in at the moment is this one here. So that's rectus femoris. So that one there will go all the way down quadriceps tendon, patella, and then into your tibial tuberosity. So that's the pathway of that muscle. So there's your attachment for VMO or vastus medialis as well. Cool. Okay, so that's your first one on the anterior compartment. Just get my PowerPoint back up there. Cool. So AIIS. So this is a good one to pause, take a screenshot of, and then you've got it for a revision. So tibial tuberosity via the patellar tendon flexes the hip and extends the knee, and it's your femoral nerve. Because it's that anterior compartment, we know that it's going to be the femoral nerve that supplies that muscle. And then these are the arteries that supply that region as well. And we'll have a look at those when we get to that section. The next muscles are the vastus group, and you've got a vastus lateralis, a vastus medialis, and a vastus intermedius. So vastus means vast, so it means big, and these muscles are huge. Okay, when we have a look at them in a sec, The cadavers that are used on this, I've said this before, they're probably in their 80s, so the muscles are actually quite small compared to some specimens that you'll see in their kind of 40s, 50s. But thankfully, not very many people end up in the labs at that age. So you'll see that these muscles, even in the elderly, are absolutely huge, really, really big muscles. So they've got a huge attachment point. So vastus lateralis means big on the outside. Okay, so this is on the outside of the thigh. It goes from the intertrochanteric line, so that's a line up here on in between the trochanters, and we've talked about greater trochanter. There's a lesser as well, but we'll do that when we get to the hip. That attaches on the greater trochanter, the gluteal tuberosity. So there's a bumpy section on the femur which attaches the glute muscles, and then the lateral lip of the linea aspera. Now, the linea aspera, we have seen that before. It's on the back of the femur. Okay, so this muscle wraps from the front all the way around to the middle of the back of your femur. It is huge. And it attaches onto the tibial tuberosity, which we've just seen. Femoral nerve again, because it's in the anterior compartment. Let's just have a look at the next couple, and then I'll show you the next few videos. So we've then got vastus medialis, and we've seen a picture of this. This is your teardrop muscle, so the one that's really developed in footballers. And you usually think, oh, it's only a little muscle on the inside of the knee. This is massive as well, okay? So look where it attaches, medial portion of the intertrochanteric line. That's up here. That's near your hip, okay? So your VMO, your vastus medialis, and sometimes it's called VMO, vastus medialis oblique, because it's got oblique fibers. It attaches up near greater trochanter. It's huge, absolutely huge muscle, and then the belly of it gets bigger as it goes a bit further down the leg. This also attaches on the linea aspera, which is around the back of the femur. Okay, so that, and we'll have a look at the line in a sec. So you've got vastus lateralis wrapping around the outside and coming around, vastus medialis wrapping around and coming around, and they both attach on the back of the femur. So underneath your hamstrings, they're absolutely huge. And then the last one in this area is your intermedius. There is another muscle, but we haven't. There's not usually cadaver images of it because it's usually gone by the time that they've what do you call it? Infuse the body with formaldehyde. It tends to disappear, or sometimes it gets dissected out. So we've got vastus intermedius, which we can see. I'll show you the other muscle in a sec. This is anterior and lateral surfaces of the body of the femur. So this is mainly at the front of the thigh. Okay. Intermedius means in between. So you've got lateralis wrapping all the way around to the back, medialis wrapping all the way around to the back, and then sitting in the middle, in between them, is your intermedius. And then over the top of that is your rectus femoris. And those are your quadricep muscles. So let's have a look at the rest of them. So this is lateralis and medialis together. Let's have a look at those. So there's your rectus femoris. This is your vastus lateralis just here. Is that showing rec fem again? Yeah, here we go. Let's get the right one. Here we go. Okay, so there's medialis. This is VMO. So you can see the oblique fibers of the muscle there. And then this is lateralis on the outside. Yeah, so this is the outside of your leg. Look how massive that muscle is. And it wraps all the way around to the back of your thigh and then attaches on the linea aspera at the back. There's the vastus medialis attachment as well. So if you didn't know, if you weren't aware of what you were looking at there, you would think you'd be looking at the hamstrings. But this is where your vastus lateralis attaches. So the lateral lip, this is the linea aspera, so the white line. So that's where it attaches just there. And even up here. Okay, so it's huge, huge muscle, hence vastus. And there we go. So there's the intertrochanteric line all the way around that, down that linea aspera. And then there's the medial attachment just there. Huge muscle. Okay, so your VMO is not just here on the inside of your knee. It comes all the way up to near your hip. Okay, all the way down there. And that's your linea aspera just there. And I think that was it for that one. Yeah. And then this is your intermedius. Let me just show you this one. So this is the one that's in between those two. So there's your greater trochanter. There's the medial side of the knee. And this is your intermedius. So look at that massive broad attachment just there. And then also comes down and joins into that quadriceps tendon. So all of the VMO, the vastus medialis oblique, the vastus lateralis, and intermedius, and rectus femoris all come down and join onto that patella, okay, and via the quadriceps tendon. And then they all join into the patella, wrap around the patella, and then down onto the tibial tuberosity. So let's just show you this one. This is the other little muscle that's just underneath, and it plays a very important role. So this is articularis genus, and remember we were saying that genus is to do with the knee. This little muscle here is deep to intermedius, so it's only a small little muscle, and it attaches onto the suprapatellar bursa, so that little pouch above the knee. So when you want to extend your knee and then the patella moves up in the groove, to move the pouch out of the way, the articularis genus will contract and move the pouch so that the patella can come through. Okay, so it all works in tandem with each other so that you can extend the knee. So the anterior surface and distal third of the body of the femur, so around this bit here. So on the front, and then the distal third is the third that's furthest away from the midline of the body, and its insertion is on the synovial membrane and joint capsule. Okay, so it pulls the suprapatellar bursa superiorly. So when you extend the knee, it moves it out of the way so it doesn't get caught behind the patella. And then that is innervated by your femoral nerve and supplied by the femoral artery. Okay, because it's in that anterior compartment still. Okay, cool. So that is the anterior part of the knee, or anterior compartment of the thigh, muscles that act on the knee. Just get rid of that. There we go. So if you have any questions about that, give us a shout in the group over the week. What we're going to do next Monday is have a look at the other compartments. So we'll have a look at the posterior and medial compartments. We're obviously going to look at the pelvis a little bit because of the attachments up there and then the influence that has below as well. And when we look at the adductors in particular, there's some real key points there that make the blood supply to the whole leg make sense. Okay, so that knowing that part on that medial side is going to be really important for that section as well. So I hope you guys had a good Christmas, and thank you for joining me on this Bank Holiday Monday. Like I say, I'll be back next Monday, 10 o'clock. If anybody wants to message me about any of the mentoring stuff that we're doing, then feel free to get in touch if you think that would be good for you. Or if you think it'll be good for someone else as well, then obviously give them my details and we'll point them in the right direction. But otherwise, have a great week. Enjoy New Year, and we'll see you in 2022.